Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. It gives me great pleasure today to have this great symposium on revolutionizing cardiovascular screening in diabetes. I welcome everybody who joined virtually. Hopefully, a lot of people will be joining as we go on. And we wish next time also we have in-person like symposiums such this one. I'd like to thank the organizers for this great symposium, ODA and Roche Diagnostics. And this symposium hopefully will be interactive. It will be very fruitful. And the way we are going to run it, I'll have introductory slides, then we'll have a very eminent speaker, Dr. Arif. I will introduce him later. Then we'll play a video, and then we will have the floor open for your comments and questions. So I'll start my part. So do you know what is this? So this cockroaches. So in old times, I mean, this is commercial advisement. If you see one, this was done for the beef bath, this advertisement, and if you see one, then the others are hidden, and you're likely to get them on. And this is exactly similar to the diabetic complications. You know, diabetes affect every part of our body. And once you see a complication happening at one part, it's likely that you'll have other complications. You see proteinuria or kidney disease, then the heart could be affected, the retinopathy. So this is what happens in diabetic patients. And coinciding with this, BIF is like preserved ejection fraction, which is also will be discussed maybe in our presentation today. Now, this is the kind of care that we give to our patients. So we as endocrinologists or like GB or pharmacophysicians or primary physicians treating diabetic patients, we just concentrate basically in the glucose. So we are like glucologists or sugaralists. This is commonly what we do. Now, better than this, that people treat like diabetes, physicians treating complications. But this is what happens. The patient with diabetes goes to the nephrologist. He would just treat the kidney and he would neglect the other things. Specifically, sometimes the lack of awareness, lack of tools, lack of like time. A better physician would be the one who would see the patient as a whole. He would screen for the complications. He would find them and he would address these complications. He would try to treat what he can and he would refer to the concerned specialty, the others. So that's even a better practice and a holistic approach to the patient. And probably better than this is trying to prevent actually these complications from occurring. Now, preventing the complications, of course, the A1C is very important. The blood glucose is very important because we know that each 1% increase in HbA1c is associated actually with 40% increase in microvascular complications, 40% increase in macrovascular complications, and even 40% increase in overall death. So reduction of this glycemia is actually means reduction of all of these. But nevertheless, you would have a lot of residual complications, and you need to address the cardiovascular risk factors. You need to address the lipids, the obesity, and the other things. And a lot of times, you cannot control the A1C. And nowadays, over the last few years, we are moving to something which is called disease-modifying drugs. And for the first time, we can modify, for example, heart disease. We can modify the kidney disease. we did not have the tools previously to do this, but nowadays we have them. So it's very important to detect things and to detect them earlier and try to modify them. And you look at the guidelines, the ADA 2024, 2025, and you see these drugs which modify such diseases, and they are very emphasized almost in all guidelines. We know that heart failure, for example, is the most common cause of cardiovascular related hospitalization. Type 2 diabetes, very common. The cardiovascular disease in general is very common in diabetic patients. Heart failure is especially very common in our era and area and the world as a whole. And nothing kills the economy more than hospitalizations. Now, Bill Gates said AI will replace doctors, teachers within 10 years. I'm not very sure about teachers, but I don't think in the coming few years it's going to replace doctors. Now, I think our eyes are better. Our brain is better than computers. We can analyze, we see the patient as holistic. But even if we have our eyes, if we have our brain and everything, we cannot do things without having the tools. So we need the tools. And in today's presentation, which I will introduce now, we are going to speak about a very important tool actually in diagnosing heart failure and diagnosing it in its very early stage so that we can prevent the symptomatic form. Now it's my great pleasure actually to welcome Dr. Arif. I'll stop this screening and then okay. So Dr. Arif is very well known to all of you. He's actually one of our great friends. He is a leading figure actually in cardiology, both nationally and regionally. He's consultant cardiologist specializing in advanced heart failure, transplant cardiology, and cardiac imaging. And currently, he's working at the National Heart Center at the Royal Hospital. Dr. Arif completed his advanced cardiology and imaging fellowships in the United States, where he served also as assistant professor of cardiology in University of Nebraska. He is a fellow of the American College of Cardiology and other also several associations. In Oman, Dr. Arif has played a pioneering role in shaping advanced heart failure and heart transplant program, and recently leading the country's first successful heart transplant, a milestone actually in achievement in Omani healthcare. And he is very well known for his great publications. We cannot find probably better than Dr. Arif to give such a presentation. He is an excellent presenter. I have enjoyed several lectures that I have attended, Dr. Arif. So please join me in welcoming him. Dr. Arif, the floor is yours now.
Well, thank you very much, dear Dr. Ali. It's such a pleasure and honor to be in here and to join this elegant and interesting talk. It's great actually, to see this such collaboration between friends, colleagues, expert in the field of metabolism and endocrine and diabetes, and as well as you alluded to earlier in your talk or brief discussion, this is where kind of we need to move a little bit closer to the patient and bring everything together, like kidneys, heart, metabolisms, and endocrine, or what we call a CKM. Thank you very much, Dr. Imad and Ilham, for this opportunity, and thank you, Roche. Again, thank you very much, Dr. Ali, for this nice and sincere introduction. Really appreciate it. I just wanted to make sure if you guys are able to see my screen.
Yes.
Perfect. Okay. So as Dr. Ali alluded to the beginning of the talk, I had the task to talk about the revolutionizing of cardiovascular screening in diabetes and what we could do a little bit one step before that we end up like diagnosing these patients with cardiovascular complication. And Dr. Ali said clearly that among the top leading cause of cardiovascular diseases or problems with people with diabetes is heart failure, which give me this opportunity to talk and discuss a little bit of cardiovascular diseases and in particular diabetes, heart failures in the setting of diabetes. These would be my main objective of today's talk. I would talk a little bit and highlight on the cardiovascular diabetes problems and integrate such more sophisticated tools such as biomarkers and imaging screening tools. And lastly, I will shed a little bit of light of the practical clinical pathways and what will be as like a take-home messages for our dear audience to apply in their daily practice whenever they're seeing patients. I know I might not have time to outline all these points in my today's talk, but I will do my best to shed light on the most important aspect of them: cardiovascular, diabetes, equal to heart failures. How can we screen? How can we prevent? And what is the best way to make our patients live free of cardiovascular diseases whenever they're having diabetes? So if we talk about the prevalence and the incidence of the disease worldwide, there are up to 537 million people are affected with diabetes. I'm not a diabetologist or endocrinologist, and I know most of you know this better than I do, but it's very important for me whenever we talk about diabetes, we always link diabetes with the main cause of death in this population. Over 75% of these patients who are affected with diabetes are from the low and middle income countries, which are unfortunately the one affected the most. They don't have access to most of the essential medications or the evidence-based therapies, let alone the socioeconomic standard, the poverties, and access to educations, and which will be a big, important chunk of whenever we keep talking about prevention. Diabetes, unfortunately, back in 2021, caused more than 6 million deaths during that year. And when we talk about the financial burden, there are about 316 increment risk over the last 15 years just because of the cost of diabetes. Let alone people with IGT, there are at least 541 million who've been facing or placed at higher risk of developing diabetes in the coming years to come. Since we're in the Middle East and we're not in the isolation from the rest of the world, if you just pay a little bit of attention to the center figure, you can say they're the most kind of, if we combine it with Africa, the most risk of increasing diabetes or projected to increase in the next 20 years plus, it's basically in the Middle East and Africa. And as we talked earlier about it, the access to the better education, socioeconomic standards, availability of the medications, availability of the more life-saving or evidence-based medication in these countries, let alone lack of physical activities and other risk factors. So we're projected to have at least 136 million of people being affected with diabetes by 2045 just in the Middle East and North Africa alone. So the reason is we care so much about diabetes and the risk of being projected, and we're here in the Middle East or the GCC countries, not in isolation from the rest of the world. Diabetes prevalence is among at least 15.7, at least in our beloved countries, which is considered to be a little bit on the rise as we kind of have the numbers projected over the last few years. The main risk factors for such things having diabetes in these settings There's always risk of silent ischemia. Remember, people with diabetes don't have the classical presentation of angina or chest pain as we see it on the regular or the usual people. Part of it because of the nervous or the nervous system denervations, or the way how things are presented of the inflammations and the scar burdens and the way how the myocardium is structured. They don't have the classical way. And no surprise, a lot of time we see this patient, they come to us and we do an EKGs or echocardiogram, and we see some areas of scars or decreased motion wall abnormalities or even Q waves in their EKGs. When we also risk stratify them by doing a coronary calcium score or coronary CT scans, there are always some evidence of atherosclerosis disease in their arteries, meaning these people, whenever they have a longer stay of diabetes, whether it's type 1 or type 2, there are always some elevated risk of cardiovascular, whether it's apparent and obvious, or kind of caught at a late, at earlier time, or it's a little bit silent in a lot of the cases that warrant further workup and investigations in general. So diabetes is an important risk factor, as Dr. Ali said earlier in his talk. And we're talking about people who are asymptomatic, yet they might have evident some structural changes, like they have hypertrophy in their walls. They might have had some previous or silent infarction or ischemia. They might have had some regional wall to some degree, or they might have early changes like in their strain analysis or diastolic dysfunctions. And not to forget about the valvular pathologies, especially aortic stenosis and to some degree some mitral abnormalities. So diabetes is a form of stage A heart failure, if we kind of classify it as a risk factor. Similar to people who are on chemotherapy or radiation therapy, they're completely asymptomatic. They don't have any presentation of their heart failure, but just having diabetes along some other risk factors, they already, by the definition of American College of Cardiology and the HFSA and the AHA, put them at a risk of heart failure. And I always tell my fellows and junior doctors, it's just something's important. We put it actually, when we risk stratify these people, to put it in your note or your risk assessment, because there is something that I always need to remind myself and talk to my patient to be more aggressive about treatment and more aggressive actually when it's come to screening and treating these patients or taking the initiative of being as aggressive as possible. So for that reason, earlier detection in these people would have prevented or permitted earlier implementations of effective strategies. We've just mentioned as the introduction and what's also been discussed by Dr. Ali, the main cause of death of these people is cardiovascular and heart failure among the top of the bad guys when it comes to diabetic patient. And hence, it's very important actually to understand the pathophysiology between them. Then we always ask ourselves, what is the sort of mechanism and why there is always a risk for the incidence of heart failure? The hallmark of the risk factors or the pathophysiological changes, whether it's at the cellular level or the macro levels, it's the prognosis or progression to what's called diabetic cardiomyopathy. Diabetes is a pro-inflammatory, systemic, chronic condition. Whenever there is a component of other risk factors, such as hypertension, dyslipidemia, lifestyle, sedentary life, or decreased physical activities, obesities, and you name it, there is always an increased risk of RAS system activation. There is an abnormal remodeling of the myocardium, which could lead to remodeling of the LV, and later could lead to hypertrophy or concentric LVH. There is impaired calcium handling. There is increased fatty acid utilizations and free fatty acid or oxidations. There is autonomic dysfunction, abnormal neurohormonal activations or upregulated. This all lead to fibrosis and inability of that normal myocardium to become abnormal. And hence, with time, even there are some animal models studies or preclinical studies were done. They studied the strain analysis, which is a precursor of these people before they have diastolic dysfunctions or even systolic dysfunctions. They found that their global longitudinal strain was not completely normal. And these sort of kind of, the mechanisms between the diabetes, the other conditional risk factors, and then the incidence of having a diabetic cardiomyopathy in the longer term. For that reason, diabetes is considered as the or cardiovascular disease is considered as the leading cause of death in these people. It's very important to early diagnose these people, and we need to implement very important preventative measures to look for them. And hence, that will mandate us to have a proper and organized screening way whenever we deal with people who have diabetes in order to prevent the incidence or in order to prevent the occurrence of cardiovascular complications, namely here heart failures in the future. Among the major trials, whether it's European or American or guidelines, all of them they stress on the importance of routine monitoring, and there is no surprise because we prefer prevention over whenever it's kind of no cure. Prevention could prevent multiple unrelated or unwanted complications of these diabetic patients in general, and namely cardiovascular. I mean, of course, renal, retinal, neuro, they're also important complications, but cardiovascular, unfortunately, is the main cause of death in these people. However, these guidelines that in practice, they're not fully addressing all the risk factors and emerging conditions that affecting patients' cardiovascular health. For that reason, emerging risk factors is very important for them to be identified and integrated into the emerging risk factors to have a routine assessment and hence implement this in our guidelines to prevent this such things of happening in the future. And that's one of the things a lot of these people with what we call them asymptomatic who are diabetic, they acquire a lot of time part of this metabolic syndrome. They have diagnosed or have missed diagnosis of HFpEF. The problem is the minute we develop HFpEF or heart failure in these people, your risk will double and triple when it comes to hospitalizations or even mortality. Also, it's a surrogate at the time when you have diabetes or the presence of cardiovascular, such as heart failure. There is also a precursor of them having preclinical or asymptomatic or non-significant coronary artery disease. Making early recognitions is very crucial in these people to prevent serious complications in the future. One of the clinical cases or vignette that we come across to, a patient in their middle age, 56, commonly male, with diabetes, report some exertional fatigue. Some people tell them actually this is because of aging, this is because of the conditioning, this is because of actually you just recovered from a flu or something like that. They ignore the symptom, they ignore actually this red flags, but because they're missing the routine assessment or having an annual based cardiovascular screening, this is where these people, such as silent ischemia or early heart failure, such as HFpEF, are missed, and what we call them a missed opportunity for earlier detection. And there's a lot of serious consequences when it's come to miss such conditions or diagnoses. The minute we diagnose these people with CAD or heart failure, your risk of death or rehospitalizations or poorer quality of life just goes sky high. For that reason, comprehensive screening is very important to prevent such things happen to this 56-year male. Then when we talk about the screening tool that we have in hand, the current tools or the traditional tools we always exclusively or universally depend on EKG for the good or the bad of it. We also depends on stress test, mostly treadmill, but remember, quite a lot of the time, these people have already developed peripheral artery disease or peripheral neuropathy, and hence doing a treadmill test would be challenging, and hence we need to do some sort of nuclear or chemical test. And that's why, for quite a lot of time, it might not be adequate enough to test these people for subclinical or asymptomatic CAD. And we need always to ask ourselves, are there any tools that we need to play and we need to ask ourselves to get and implement in here to have a better risk stratification. So we need to have this concept of that there is no one thing that fits all. You need to tailor everything so each tool or risk stratification prognostic calculator for your patients individually. What does apply for one particular patient does not necessarily apply on the other patient. And as a result, we need to take each patient's different. We need to tailor their risk. We need to tailor their comorbidities. And hence, we need to justify when and where and how aggressively or periodically we need to screen for these people. The most commonly used calculators whenever it's come to AACVD risk predictions in the next 5 to 10 years for any cardiovascular disease, and one of these populations is the diabetic patients. The most commonly used is the Framingham risk calculator, the SCORE2 diabetes calculators. But remember, these risk calculators were done in certain population, certain period of time, and they're not representative of the whole population. And for that reason, we need to have something more tailored and more specific in order to achieve that precision medicine in giving that patient the best treatment possible. And this is doable by using some sophisticated tests, whether it's in the form of imaging or whether it's in the form of less invasively more available, such as cardiac biomarkers. Calcium score of the coronary arteries among the most globally and universally being adopted and being studied and validated in multiple studies and trials, and sort of kind of class one indication for these peoples whenever we look for any predictions of risk score, for especially for the low to intermediate risk in general, and whether these people will benefit from statin or lipid lowering therapy to prevent or reduce the risk of cardiovascular event in the years to come. Troponin, or specifically high sensitivity troponin, has been a major player in assessing people's risk or incidence of myocardial injury, and hence aiding in the early detection of acute myocardial injury or ACS. And among all of them, when it's come to heart failures or cardiomyopathy, NT-proBNP or natriuretic peptide are the sort of gold standard whenever it's come in aiding and helping and also looking for the prognostications and risk actually of hospitalizations or morbidity in these patients, especially at an earlier stages. If we expand our risk stratifications and precisions tools to assess for any associated risk in the setting of diabetes, retinopathy is another kind of tool that being used and assessed and a marker of aggressive disease behavior in diabetes, albuminuria as well, and also monitoring both this retinopathy and albuminuria will provide a valuable insight as if these people not probably at the microvascular level they are having the disease, but probably there is also a progression of a macrovascular level to be involved, such as peripheral artery disease or coronary artery disease. And if we sum up things together and we see what out of all of these tools are available right now, whether it's the risk scores calculators or imaging tools or biomarkers, we see with NT-proBNP and high sensitivity troponin, there is 79% of these patients who are diabetic and they're subclinical and asymptomatic. They have already shown to have elevated NT-proBNP. And we need to keep this in the back of our mind whenever we risk stratify these patients in parallel to people who are diabetic and asymptomatic, but their NT-proBNP is either normal or barely elevated. What are their prognosis? What are their likelihood of developing cardiovascular disease and namely here heart failure? In comparison to echocardiogram or coronary artery calcium score, or maybe more sophisticated tests such as SPECT or stress MRI, there is about 45% reductions of the cardiovascular mortality when we combine that with calcium score to predict the risk of them having a major cardiovascular event in the next 8 to 10 years in diabetic patients. In comparison to the least probably, how to say, precise or predictive tool in the clinical risk scores, such as watch diabetes or scores diabetes, would give us about 11% improvement in risk prediction, especially when using scores diabetes. So this diagram or this slide will give you a flavor of what the things and tool we have in our hand and how precise we want to predict the risk in that particular patient. And once we know that elevated risk or how we want to be aggressive with that patient, then we can always tailor our therapy, whether it's pharmacological or non-pharmacological, for years to come in that particular patient. Since we talk about NT-proBNP, and this is sort of kind of a biomarker, sort of kind of guided sort of management, excuse me, I wanted to highlight a little bit and shed lights on the role of NT-proBNP and how did that imply its actions on the myocardium. So NT-proBNP is secreted in response whenever there is a stress or stretching of the myocardium. This is elevated in the context of fluid overload, increased pressures in the chambers, especially the left atrium or even the LV, or when there is an overt heart failure. And if you go a little bit deeper and understand and studies the precursor or the nitric peptide, so proBNP or the molecule, it's basically secreted from whenever there is a stretch or there is a stress on the wall of the myocardium. When it gets cleaved, it usually get cleaved into two fragments. The N terminal, what is called the NT-proBNP, or the C terminal, which is called the BNP. There is no physiological function for the NT-proBNP. It remains stable for up to 3 days in the room temperature. Unlike the BNP, it's usually biologically active. It has a nitrolysis effect and diuresis effect. It also causes a peripheral vasodilation, and unfortunately, it will cause dysregulations of RASi system, which has a consequences effect on the whether in the myocardium or the peripheral circulation. With time, whenever we see it increase, the instead of a point time or the point number in time, we usually look at the trend, whether it's going up or coming down, as a surrogate of how that heart failure patient is behaving over time. The lower it is, the better survival, less hospitalization, better symptoms, and like will keep going up. And this was studied in numerous studies. In one of the major studies or trial done more than 20 years ago, the cutoff numbers for NT-proBNP was found to be 125. This is where the risk or earlier detections or structural changes of heart failure, or let's say symptomatic or class C heart failure happens when the numbers is higher than that. Unlike when you have a number lower than that or close from that or staying in that range. This is in the context when you have some structural changes. This is in the context when we have some dilatations or even increased filling pressures. Putting all of these things together will give you an idea that your patient is progressing from stage B to a stage C heart failure. And it was shown that it has a great discrimination's ability for cardiovascular event when it was followed up for up 1 year in these people, as long as we have a cutoff of 125 and above. Also, a cutoff of 125 and above of NT-proBNP was also found to be a good discriminatory tool or ability for future heart failure hospitalization. This was also seen in a study of more than 16,000 with a history of diabetes and risk of cardiovascular events, and they studied their NT-proBNP. What they found in these people, elevated NT-proBNP was enough to predict heart failure hospitalization when the numbers is more than 125. Not only that, NT-proBNP sharp increase in it usually precede the heart failure hospitalization just during that time of the studies. So it's not only looking at the numbers over the study period, but also looking at the trend of how sharp of and wise it's there to predict these heart failure hospitalization to time to come. We'll have hemoglobin A1C. We'll have albuminuria. We'll have also other tools or blood biomarkers. But believe it or not, out of all the major tools that been predicted for cardiovascular, it was found that NT-proBNP in a study of about 544 for people were measured at baseline and followed up for a year with a median follow-up of 40 years, NT-proBNP was more superior with a significant p-value of less than 0.001 when predicting cardiovascular outcome in people with diabetes. It just tells you it's not only for people who have established cardiovascular disease, but let alone for people being predicted to have some cardiovascular disease, especially heart failure in the future. The same things also apply for albuminuria. When in another study, people of a total 1,071 with diabetes, they studied them with a median follow-up of 30 or mean follow-up of 33 months. They found that the elevated NT-proBNP more than 125 with the urine albumin creatinine ratio was enough to predict cardiovascular event in the future. But NT-proBNP alone, with even a normal or mildly elevated albuminuria, was superior and enough to cause or predict outcome in patients of having cardiovascular event in the setting of diabetes. Also, when we mentioned earlier about imaging, biomarkers, and risk score calculator or clinical risk score calculators, such as the SCORE or the EAC, AACD, it was also found that NT-proBNP provides a more accurate and robust data to predict the cardiovascular event in these people during the time of the studies. So it just tells you and highlight how important these biomarkers, even in asymptomatic, without established cardiovascular disease or heart failure, just the mild elevations beyond the 125 by itself, it's enough to predict outcome or poor prognosis in general. Also, among the major studies, STOP or Pontiac 1, people with type 2 diabetes and elevated NT-proBNP, when they studied and followed up for 2 years in 2 arms, they benefited more of upfront up-titration of neurohormonal therapy with uracil inhibitors as well as beta blockers. It was found that hard outcomes or primary endpoints such as hospitalization or death was less compared to the people who were just on the regular treatment or regular monitoring zone. And these were well highlighted among 2 trials, the STOP-HF and the Pontiac 1 trial. Also, people were studied in other trials where dapagliflozin done and studied them of total of 14,562 patients, assessing their median level of NT-proBNP, even a slight increase a slight increase of NT-proBNP as baseline was enough to predict risk, heart failure hospitalization, or cardiovascular death by just having it elevated. And on the same time, the higher that level of the biomarkers elevation, and with the addition of dabigatran, one of the well-known and effective SGLT2 inhibitors, there were significant reductions in MACE whenever we saw that NT-proBNP was reduced in comparison to people who were only in placebo. So whenever we come to the guidelines and recommendations and what we have there and how we could do and address this into the clinical practice, back in 2022, the American Diabetes Association, from a consensus paper, people who are at stage A, i.e., they don't have heart failure, they don't have any structural changes, they don't have symptoms. However, they're at risk. Like, for example, they're diabetic, hypertensive, they're receiving cardiotoxic medication, radiations, smokers. So whenever their NT-proBNP or BNP or high sensitivity troponin are within the normal range, and especially we're talking about diabetics patients, the recommendation is to repeat it at least in 1 year. In contrast to people who are stage B, meaning they don't have the symptoms, but they already have some structural changes such as LVH, maybe some moderate valvular disease, some global longitudinal strain changes, with an elevated biomarker such as NT-proBNP more than the cutoff of normal 125, then these people in the setting of diabetes, then these people are recommended to have and to be supplemented or complemented by imaging tools such as chest X-ray or echocardiogram. On the other side, when you have a patient who are diabetic with a stage C, or maybe when they're in the stage heart failure, and they have overt clinical signs of heart failure, such as JVD or the usual presentation of right-sided or left-sided, then we will treat these patients according to the guidelines, whether they're HFpEF, heart failure mid-range, or HFrEF in general. Also, there is also multidisciplinary personalized care approach if we want to be a little bit more sophisticated for our diabetic patients in a hope to prevent progression of their already known cardiovascular disease or prevention of these conditions in the future. For example, medical management is ARB, SGLT2 inhibitors. They're among the first medications to be used in these patients whenever we want to start them. We try to avoid any DPP4 or sulfonylureas as possible, especially in the setting of heart failure. We try to be as cooperative as much as possible with in the setting of multidisciplinary approach, nephrologist, neurologist, endocrinologist, interventional cardiologist, heart failure cardiologist, and also clinical aid or paramedics to help and optimize the medication. If these patients are obese, there are more data now to use GLP-1 receptor agonist. If their patient having some renal risk or their HFpEF, then we can always use non-steroidal MRA. So this is the way how we precisely and targeted, we use targeted therapy for these people to prevent unwanted complications or progression of their disease in the future. With the recent and updated 2024 American Diabetes Association guidelines, they recommend NT-proBNP screening for all the asymptomatic cardiovascular patients with diabetes and starting the treatment of these patients. So the treatment in stage B heart failure to reduce the risk of progression, then the recommendation is using ACE inhibitors or ARB. If they're higher risk or established cardiovascular, if diabetic kidney disease, then they recommend the non-steroidal MRA finerenone. If they're having higher risk or established cardiovascular disease, then they recommend at the first line of therapy SGLT2 inhibitors for the kidneys, the heart, and also to manage their diabetes. SGLT2 inhibitors one or two inhibitors, sotagliflozin, or even the SGLT2 inhibitor by itself such as canagliflozin, dabigliflozin, and empagliflozin being the one are in the evidence-based practice. The ADA also 2024 recommendations says it's a level B recommendation. Adults with diabetes are at increased risk for the development of asymptomatic cardiac structural or functional abnormalities, i.e. stage B heart failure, or symptomatic stage C. Consider screening these adults with diabetes by measuring their natriuretic peptide, either BNP or NT-proBNP, to facilitate the prevention of all progression of their heart failure. So the 2023 Diabetes Technology Society consensus recommendation for routine biomarker screening in these people with diabetes, any patient with type 2 diabetes to begin screening at any age. For type 1 at age 3, not before age 3. The duration of diabetes before initial screening for type 2 at any time of diagnosis, whereas for type 1, 5 years following the diagnosis. It has to be on annual basis. The biomarkers either BNP or NT-proBNP, and hence we're so lucky to have it right now, and we just change our platform using the Roche core lab for the NT-proBNP, and we're hoping sometimes in the future also have our point of care NT-proBNP from Roche, which always can translate the results back and forth and make things much easier. Not only that, most of the landmark trials, and one of them is the strong HF trials, when they studied and they based their results on the assessment of using the Roche NT-proBNP. And the time of the testing to be started at any time of the day. And lastly, the European Society of Cardiology guidelines for the management of cardiovascular disease with diabetes, their recommendations, class 1, level B evidence. If heart failure is suspected in these patients, then it's very important to look for the NT-proBNP. And if I sum up all of the 2024 ADA and ACC and HAA and HFSA 2023 and the European latest heart failure guidelines and recommendations for people type 1 or type 2, we usually recommend the NT-proBNP, mainly or namely NT-proBNP, and if there is imaging needed, then either echocardiogram or as per the EEC, cardiac MRI, if there is abnormalities or signs or elevation. Whenever there is an elevation in the setting of diabetes of NT-proBNP in more than one occasion, then we need to complement that by imaging such as chest X-ray or echocardiogram. And when there is some structural changes, then upfront starting of these therapies, you can always argue whether they're symptomatic or not, and whether they have NYH class 2 or less. There's something is always an argument, but the earlier we see this patient, the earlier we catch them, the better the prognosis usually, and the less the consequences of having problems in general. I have the next 5-6 slides. I'm almost reaching the end of my presentation. It's just to talk what about the advanced cardiac imaging other than biomarkers we have in here. Coronary calcium score among the top ones. This is sort of dot in the distal LAD, distal UH elevated, meaning in the setting of coronary, or in the setting of diabetes, your risk of CAD is elevated, and hence these patients will warrant statin therapy or lipid lowering therapy. Coronary CT angiography for people who are having silent CAD, or people you're worried about doing invasive procedure, or people needing something less invasive, then it could be a cool or a great tool to be studied for these people. Cardiac MRI, as if we're complaining a 4K or 8K TB, whether regular or analog TB between echo and cardiac MRI. Excuse me, it's very important when it comes to assessing the structural, assessing for better quality and tissue characterizations. And I also highlighted for scar or LGE or scar burden. A stress MRI using adenosine or adenosine or even SPECT is very important tool whenever you wanted to rule out any exercise or stress-induced ischemia in these people, and hence they will need conventional coronary angiogram. So it's very important that we need to be very precise when we risk stratify our patient. We need to get the clinical scores that's available We use them through our phones, website. We complement that by markers and namely NT-proBNP. Then if there's any symptoms or elevation, we do that by imaging. And then I take one patient separately than other patients. And I do precision medicine because one does not fit all theory. So heart failure and diabetes have with early clues and missed diagnosis. A lot of these people will have something called diabetic cardiomyopathy. They would behave differently. They might not have the classical presentation, but when you do their biomarkers, imaging, even echo or MRI, looking at their LGE or tissue characterizations, looking at their strain analysis, sometimes even complementing that by doing a stress test or right heart cath, you would be surprised that myocardium is not normal as we thought. And hence, it will be very important. This is one of the meta-analysis or review studies we've done to assess the difference between SGLT2 inhibitors and GLP-1 receptor agonists in the study of HFpEF and diabetes. And obviously, SGLT2 inhibitors were sort of kind of the winner whenever it's come to HFpEF. Also, screening in special populations, people who are young, who are not at the cutoff, or when we screen them, like 40 or 45, what to do with these people? Whenever they have an earlier age of diabetes, or the premature CADs or FH or other risk factors, then we need to be very aggressive on these people and monitor their signs for any abnormalities, and not a bad idea to complement that by biomarkers like NT-proBNP. People like women with gestational diabetes, they're always at higher risk of diabetes and obviously higher risk of cardiovascular disease later in their life. So very important, we need to have a precision medicine and personalized screening tailored to these women so we prevent complications in the future and advise them for lifestyle medication modification before starting medication. Diabetic kidneys or diabetic nephropathy, another kind of a surrogate for cardiovascular diseases and issues, and very important to screen these patients. So all of this will lead me to the implementation and the challenges in the clinical practice. Always things that we talk about that does not necessarily apply to all the patients. So you need to individualize, you need to tailor your therapy and your diagnosis and screening for certain patients. What apply in Master X does not necessarily apply in Master Z or Y. So you need to have that things and concept in mind. However, earlier detection will always aid and help in better outcome in these patients. Prevention is always better than a cure in general. And lastly, whenever we come to barriers and solutions, there are now better tools. Nobody denies the presence of AI. We need to live with it using the digital tools such as e-consult or automated risk calculators, timely referral, working with your colleagues, doing a multidisciplinary approach on meetings, using evidence-based medicine, such as with the plethora of evidence, GLP receptor agonists and SGLT2 inhibitors, and also to add on top of that, non-steroidal MRA. They're among the best cardioprotective effects in diabetic patients in general, whether it's SGLT2 inhibitors being the first agents or among the top agents, or even complemented with GLP receptor agonists. All of these agents have to be taken into consideration. And we have so many data and studies and trials have studied these patients and found the numerous, repeatedly effect of them having a better protective. Now, the concept of CKM, cardio-renal or cardio-kidney metabolic disorders, you do one medicine or one therapy to help you prevent multiple complications in the same time. And instead of only taking one medicine to treat one condition. And this is sort of the hallmark of the newer era in treating these patients. Earlier initiations of in higher risk patients is always better. And this is what we call the precision medicine. So one of the approaches I tell people, whenever you have a patient at the risk of diabetes or having diabetes, and there is worries of with higher risk of ACVD, and they're having stage B heart failure, ACE inhibitors, ARB, and if they have REF, ARNI would be among the top medication to be started. Beta blockers, SGLT2 inhibitors, now with plethora of evidence, especially with HFpEF or mildly reduced, like non-steroidal MRA. On the other side, like silent CAD or ASCVD, statin therapy, especially high-intensity statin therapy. You can always add ezetimibe if needed. Maybe sometimes antiplatelet therapy, but that's always controversial, and you always tailor it as per your patient. And there might be also some additional considerations, such as the GLP-1 receptor agonist, reductions in the weight, blood pressures, smoking, better lifestyle, and to be more active. And since this is sort of a multidisciplinary approach, and we're talking with our esteemed diabetologist or endocrinologist, always important to work together instead of isolation. This will help in optimizing patient care, would have a better approach for comprehensive screening of this patient, and definitely will have a more strategic management plan and a great outcome in this patient. Futures is very bright. We're living in a great era right now. We have seen so many studies and medications and technologies that have changed the landscape of medicine. AI is leading the pathway. Genetic for testing for precision medicines, ongoing trials such as the ADOPT or Pontiacs are among the other studies that are going to be leading the pathways. So in summary, early cardiovascular screening is very crucial. There is no doubt about it. Prevention is better than cure. Biomarker driven, specifically NT-proBNP, and we're so lucky to have it available here. And we're hoping to have even the point of care sometimes, and we can translate or transfer our results. Help in patients who are asymptomatic or even stage A or B, heart failure risk in the future, in the setting of diabetes, having that screen will give you better confidence and idea of how aggressive you need to be with managing these patients. And always practice personalized medicine or precision medicine so you can tailor your therapy to that particular patient. Sorry, I've taken more than my allocated time. Thank you very much for listening to me, and I'll be more than happy to answer any question.
Thank you very much, Dr. Arif. That was an excellent presentation. I enjoyed it a lot, and I learned a lot from your presentation as always. And I'm sure the participants who are with us learned a lot today. I would always love to have actually biochemical test, blood test. It is rather than imaging. It's easier. It's more objective in terms of the reading and analysis. There is no waiting, there is no radiation. So that is great. So let me just remind you now, we are going to play a video, and that video would be about heart failure screening in people with diabetes. And this is a clinical implementation, and this video is going to be run by, it is the ex-president of the ADA who's going to be in that video telling us the experience in that. For the participants, please put your questions in the chat box. Shortly after this video of 10 minutes, we are going to have interactive discussion and about the comments and the questions. Thank you again, Dr. Arif. Dr. Ahmad, you want to tell something? Yeah.
والله بفكر دكتور Ali, I was thinking since we are running out of time for our questions about the evening for the participant who took their time from their evening, maybe we can skip the video and we open the floor for the Q&A because we are really appreciate that we have more than about now 80 left in the call, so I'm sure they have many questions maybe, so maybe we can jump to the Q&A. What do you think?
And I think at the same time, Dr. Arif covered whatever is going to be in the video.
Exactly.
I told you initially, Dr. Arif is one of the great presenters. I mean, the presentation is actually content, slides, and presenter. And Dr. Arif has always these good presentation skills. Fantastic. That's a good thing. Now, I encourage all of you to submit your questions in the Q&A. And meanwhile, Dr. Arif, let me ask you, is there any difference in the heart failure BIF and RIF in terms of the pro-BNP?
Very excellent question, Dr. Ali. Most of the people who have NT-proBNP elevations, it's not always correlated to the type of HFpEF or HFrEF. We know that when your ventricles are burned out or dilated or end stage, sometimes they don't stretch in the same way when people with HFpEF stretch. Meaning, remember, you have like a certain cavity or certain size dimension. And whenever put pressure on that dimension, there's always like sort of kind of markers getting kind of released from your myocardium. Usually people with HFpEF, i.e., as a surrogate for diabetes or diabetic cardiomyopathy, which is the most likely to be the occurrence in these people, the level or the coincidence of diabetes and HFpEF is way much higher than people who are having HFrEF. HFpEF, it's act more of like a restrictive type of cardiomyopathy, meaning if your ventricle at any time will produce 4 to 8 liters of stroke volume, with HFpEF, that ventricle is so sort of kind of shrink in their cavity, and they're only able to accommodate, for example, 3 or maybe 4 liters at the most. So when these people get loaded with volume, pressure, whatever you name it, then all this pressure translated or transmitted to their wall, and hence there is an elevation of NT-proBNP. So we see, disproportionately people sometimes with HFpEF or some degree of restrictive cardiomyopathy, i.e. amyloidosis, or even in advanced stages of hypertrophic cardiomyopathy, their NT-proBNP sometimes in the 1,000 or even 10,000, and yet their EF is preserved. In comparison to people who are HFrEF, or they're very end stage of their myocardium, and that whole myocardium is burned, sometimes we might not see what we call the paradoxical elevations of the NT-proBNP might not necessarily translate of a degree of how advanced that HFrEF or HFpEF. So it's more of a matter of wall stress stretching, more of that myocardium is under stress on a repeated time. We always need to complement these biomarkers in the context of the symptoms of their physical activity, the 6-minute walking test and the right heart cath we do, and as well as the imaging features, whether it's like the dilatations or whether there is a burden of scar or LGE or even strain analysis abnormalities when we do like a cardiac MRI or echocardiogram.
Thank you very much. Now we have questions in the chat box. They're saying thank you for the excellent presentation. At the level of the primary care, is ECG and clinical probable examination enough for guidance if the patient needed further higher hospital workups? So at the level of the primary care, they are asking, is ECG and clinical examination is enough? Now, Arif, can you just tell the audience, the participants, about the availability of the test in Oman?
I think this is a very practical and great question. Thank you very much for whoever asked the question. I think even at the current time, like for example in the Royal Hospital, I'm just going to talk it from more of a practical perspective. And I hope this to change sometimes very soon. The NT-proBNP or the nitritic peptide biomarkers are unfortunately restricted to certain physicians or even certain level of seniority, i.e. senior specialist or consultant. This is the level of a tertiary hospital. If this is the best practice, the answer is no. Indeed, we want our primary care physician, family medicine doctors, even outpatient internists would be the hallmark or the main stakeholders whenever it's come for screening. The problem is, by the time these people will reach to you, Dr. Ali, or to me, or to somebody in the hospital, they've already passed that zone where we could prevent the disease of happening. So what I'm hoping or envisioning, inshallah, in the time to come, or maybe hopefully maybe by next year or so, to have some sort of a framework in Oman to screen these people as we do on an annual basis for their lipid, A1C, albumin creatine ratio, also the fourth markers when it's come to blood tests, to add also NT-proBNP. To my knowledge, it is still until now not available in the primary care levels. I don't know about polyclinics or mid levels, but I do know at the primary care levels is not available. But I'm hoping, and I will see this is something's gonna be great to have it implemented, because the ECG will give you one part of the story. The biomarkers could give you another bigger part of the story, and then complementing the two of them together would even enhance your risk stratification for these people in general.
I totally agree. I mean, these patients, the whole idea is to get them early, and the majority of these patients are actually at the primary care. Now, the question is either for you, Arif, or Imad, if you can have a comment in this. So, the point of care compared to the lab, is it similar accuracy?
Yes. So if you use the Roche solution, the beauty about the point of care on lab test, they both is test standardized, which means you don't have to worry about the differences. So if your patient was admitted to the hospital and he has a blood test in the lab and then discharged, and you saw him later in the FAR clinic, and you use the point of care, then you can rely on the test to see if the NT-proBNP is going up or stable or going down. So yes, for Roche, it is standardized.
That's good, because that can give you a quicker answer and can be
Yes.
distributed easily in the future. Now,
Yeah.
one question in the chat box: so which AI do you use for determine cardiovascular risk, despite of score 2 or ASVD in your hospital? And they are thanking you. So which AI, which artificial AI,
Yeah.
Arif, which AI do you use? Yeah.
That's a great question. Honestly, in a Shifa, the whole Oman, not in her hospital alone, we don't have any of these risk scores integrated in our system. At least in the previous hospitals or place where I used to work, what we used to have, we had a different EMS system. That EMS system always they update their risk scores into the EMS, meaning me as a physician, I will come in before me seeing the patients, our med levels or our nurses, our technicians, what we call them, they are clinical technicians. They will put all the patient's background, like diabetes, dyslipidemia, family history, you name it, and whether there are any standard biomarkers or vitals that they've done recently. And when the patient comes to me, it already calculated through AI for you in a template within their EMS. Currently, what I've been doing most of the time, not only for ACVD risk calculators or the score 2 calculators, even when it's come, for example, to my hemodynamics, or when I check a Cardiovascular score or has blood score, I always use the calculators to help me with this. There have been some studies or some trials being done, or at least some services being implemented in some neighboring countries. What they do, whenever you, as a patient, go to the portal, like you have a version, like a mobile version of it, and you put your demographics and your background histories, that app is able to generate your risk without even asking a physician or a medical personnel to do it for you at the other end. So this will also give the patients an idea of where they are in the risk categories, because sometimes it's sort of kind of a wake up call for the patient to say, hey, you know what? I have not seen doctors all my life. You know, I've been doing good. I don't have any things. But at least looking at these calculators for the patients, not by the doctors, it always prompts them to seek medical help. But currently, right now, in a Royal Hospital or a Shifa system, these calculators, unfortunately, they don't exist. What I do, I just kind of go to the any of the website, and one of the most commonly one I use, MedCal calculators. There's like numerous calculators which help you to just dial in the numbers and will get you these things.
Thank you. Dr. Mariam is thanking you and thanking me. I think she's abroad attending a conference, Dr. Mariam Al-Badi. Now here there is a question. Thank you for the excellent information and presentation. Do you think the pro-BNP should be a routine screening for all type 2 diabetes? So this is the question.
I think simple answer is yes. I mean, if I reframe the question, do I do it every time the patient come to my clinic? I think logistically, no, but I would do it at least on an annual basis. You know, when you always have your patients seeing you at least once a year, it makes a sense actually, you know, at the beginning of the year, what we used to call it the annual visit, they will
Yes.
come and among your three biomarkers, or even when they check with their eyes, they check their feet, and they check actually, you know, their kidneys. Always, I think it's going to be important to integrate it into your screening on annual
Now,
basis.
in this regard, like Arif, you put that ADA 2022 consensus statement, and in that it was the frequency was mentioned every 6 to 12 months. But when you're looking at the ADA to 2025, the statement is consider testing. The statement is consider. It's not like there is, and they did not specify that it should be like annually. I would have like assumed that by now it should be that way. So do you have any explanation behind that? Why the ADA in their like latest guideline they say they did not specify the frequency and they would consider.
That's an excellent question. I don't know if Dr. Ahmad, you have some answer to it, but I think from my perspective, what I would say, I always need to individualize my patient. If I have a patient who's diabetic, who's been all their course, their A1C is in acceptable range, 7, 6.5 in that range, no a micro or macrovascular complication, they're usually active and doing things. I think if I'm going to apply this on this type of patient, probably I'm not going to yield a lot of information or risk assessment or even prevention of cardiovascular in the future. On the other side, if I have a patient already have developed some, you know, even micro or macro vascular kind of abnormalities, then these people probably I would put more stress on them, because you're going to be between two scenarios. Either you're going to be in a scenario this patient is completely asymptomatic, he doesn't have any pertain reason for me to send him to a cardiologist or screen his cardiovascular, i.e., doing an echocardiogram for him on a yearly basis, or even doing a calcium score for him, or doing some things. But yet, I'm not comfortable enough because they've already developed some sort of proteinuria. They've already have developed some sort of kind of, you know, retinopathy, you know, and I know by having this microvascular complication, we know at that time they have already developed some subclinical, even at the level of microvascular obstructions within the myocardium, but yet we don't have any symptoms. I believe these patients will benefit better than the people who we just discussed about. So I think I really don't know what the reason behind it. I don't know if Dr. Ahmad, you have some answer, but
well,
I will recognize it as per my patient.
yeah, to be honest, the text say consider, but if you look to the level of class of recommendation, it was 2A. So it means it is recommended to do this test. Also, Dr. Ali, everything in the beginning will find some resistance. For example, when we have similar educational event in another neighboring country in GCC, one of the diabetologists say, so in my country we have 1 or 2 million diabetes patients. Do you mean that we should screen annually for one? And then we said, doctor, you're already doing every year, you're doing two, 3 times HB1C. You're already doing 2, 3 times vitamin D. You're already doing 2, 3 times renal function for the kidney. And in fact, if you look at it, when they want to assess the kidney, they do kidney function. When they want the liver, they do liver function. But when it comes to the heart, we don't do any cardio-specific biomarker. We use surrogate marker, BMI, blood pressure, ankle brachial pressure. So you're already doing a lot for your diabetes patient. Adding one more test that will give you a lot of information. I think it will be soon. It will be a common practice. And one more thing I would like to add. The other question we had before, Dr. Arif, is that some the physicians say, I have access here easily to echo, so I will do echocardiogram, which give me a lot more information. The idea is that the NT-proBNP is not a replacement for the ECG or for the echo. As you mentioned, Dr. Arif, they assess the heart from different prospects. While the echo give you a lot of information about the heart as as an organ, NT-proBNP give you what is the situation at the cellular level, at the heart cell level. ECG about electricity. So these are complement each other, and it gives you a better picture about the status of the heart.
Thank you for that additional comments, Dr. Ahmad. There are a lot of questions we have to take from Dr. Mazoun. Dr. Mazoun asked several questions. We'll take only one of her questions. Dr. Mazoun, by the way, she's very active physician. Utility of ABI, ankle brachial index, maybe for subclinical ASVD screening in diabetes. A clinical test and free. Probably she's commenting we have something that is free. Why don't we use that?
It's an excellent tool. Thank you very much, Dr. Mazoun. Thank you for being with us tonight. See, all of these tools are excellent, and you use them until you get their limitation. The problem with ABI, if you have a peripheral arterial disease or peripheral vascular disease in your leg and in your arm, and you're doing that measurement, you can get false positive, especially if your disease is advanced enough, or it just coincidence you're having the disease problems in the same side or more than two limbs. So I'm not saying it's a bad tool to be used, but it's a great tool. The same things what Dr. Ahmad was talking about is when I'm going to do it for my patient, I always need to put it in the context. See, in the US, whenever they design the recommendation or the preventative measures or the task force screening, they always talk about it on the context actually of the availability of that test or the ease of the availability of that test, not only at tertiary level hospital, but also at the primary and secondary level of hospitals or clinics. Number two, the cost. How many lives I'm going to save or events I'm going to prevent by doing this test for this number of people in comparison of doing this test with this cost, but for this number of people. So I think whenever we talk and design a test, it's always important to bring it in the context of the symptoms of the patients. If all these symptoms are only exclusively like, limb ischemia, claudication, swelling, decreased sensation, you name it, then yes, it will warrant to start with ABI before, for example, doing carotid or doing maybe a calcium score. The same things. If I have a patient who's been having sort of kind of abnormal symptoms or shortness of breath or having some sort of kind of what look like cardiac symptoms, then starting with the cardiac imaging, then other thing else. The ACC, the AHA, and the SKY classification criteria, I think from 2023 or 2024, the updated one when it comes to the screening, among all the tools to risk predict your cardiovascular event for people with at least mild to moderate risk, or the initiation of statin therapy or lipid lowering therapy, they found among all of these tools, such as the carotid intimal thickening, ABI, waist to hip ratio, calcium score, among all of them, putting the cost, the logistics, the risk of radiations, you name it, coronary artery calcium score was among the most robust, reproducible, cost-effective, easily available, and accessible, and the cheapest one when you kind of apply it for the populations at home. But does that replace ABI? The answer is not. I think you always tailor it as per your patient. But among all of them, if you want really to know the risk equivalent, because remember, when a patient has PAD, when a patient has diabetes, When a patient have, like, for example, inflammatory conditions such as HIV or even advanced rheumatoid arthritis, these are, or CKD, these are CAD equivalent. So by the end, the mode of death or complications in these people is a consequence of cardiovascular death. So the best one's going to yield you the best answer is doing some coronary assessment or calcium score for these people.
Thank you, Dr. Araf. I think the questions are a lot. This means it's like really a great lecture, a great interaction. I loved it. For the sake of time, I mean, if we continue with the questions, I think today until like midnight we'll stay. But I'll take just few questions, and Araf, I want you just to give them brief about this way. So maybe one question asking about the conditions which might cause false elevation and false decrease in Pro-MB? Just quickly, Dr. Arif. Yeah.
This is an excellent question. The most common one I want you to remember, obesity. So many people who are having florid heart failure, their BNP is barely elevated or normal. So just keep that in mind. BNP hates fat. So much fat, you're not going to raise that BNP. So just keep it at the back of your mind. The other condition as well, I'm not going to, just for the sake of time. There also, NT-proBNP doesn't always equal heart failure. So I just want you to keep that in mind. NT-proBNP or natriuretic peptide, when it's positive, yes, it aids you in getting or reaching to a diagnosis to heart failure. But when it's negative, you does not mean you don't have heart failure. Remember, heart failure is not always about volume retention. Heart failure is not always about edema and volume overload. At least 1/3 or 1/4 of these patients, or 1/4 of these patients, what we call them the dry or euvolemic. So there is no stretching in their wall. So BNP either would be normal or mildly elevated, but does not exclude a florid heart failure, because these people might have a low output state or have other forms actually of heart failure. Other conditions, people with CKD, people with pneumonia, people with even massive PE, stretching on the wall, people with a mass inside the heart, does not necessarily translate to heart failure. So I always put the BNP or natriuretic peptide in the context of the clinical picture, imaging, if I have ECG tracings, and the trend of that NT-proBNP. What was my NT-proBNP at the beginning? What is my NT-proBNP before the discharge? And what is my NT-proBNP or BNP when the patient come and see in my clinic? So instead of just getting one absolute data at point in time, it's looking at the trend. So there are multiple other numerous causes for elevations of NT-proBNP, and also among the most common causes of low NT-proBNP or falsely abnormal is obesity or excessive fat.
That was excellent. And I think also the acute versus the chronic heart failure cutoffs, maybe you highlighted that already. I mean, there are a lot of questions. I think for the sake of time, unfortunately, we are going to stop here. And Dr. Araf is approachable whenever you want to, like, you have anything, you can contact him. I'm sure he would be available and happy to answer you. I'd like again to thank everybody. Maybe Dr. Ahmad, you have something to say?
I I just want to thank you again, Dr. Ali, Dr. Arif, and the organizer for this event. To be honest, it is much more than what we expected. It's too late in the evening, and there are so many people joined. So big thank you to all of you and to Dr. Arif for this wonderful educational event.
I think in the last like few years, we are having symposium with the cardiologist, with the nephrologist. The cardiologist and nephrologist would listen to the diabetologist. Since we have these innovative like tools, both the diagnostic ones and the therapeutic ones, we are meeting, and that's great because this like makes guidelines quicker, easier collectively. And I think we should, as diabetologists, take things concerning about the heart failure, and this from the cardiologist. We don't wait for that, and that's maybe one of the things that we state, just to put it very, very solid. And I do agree with Dr. Ahmed that things when it at the start there will be some hesitancy, because we know like the burden of diabetes. But eventually, if you take it as cost effectiveness, I'm not sure whether in the near future we'll have some cost effectiveness in this regard, but it would be very cost effective to detect people earlier before they have the symptoms and treat them and prevent like heart failure and hospitalizations. Thank you again. Thank you very much, Dr. Arif. We enjoyed your talk as always. I'd like to thank the participants and we will close now.
Thank you. Thank you very much.
Thank you. Have a lovely night, and we hope to have maybe a round 2 session because of this interest.
Oh, Ilham, we forget you. We thought, okay. So Ilham did like a great job in terms of organizing this. Thank you, Ilham. Thank you.
Have a lovely night. Good night.
تصبحون على خير.